Welcome to The Breakdown, the orthopedic podcast where we dig deep into the world of bones, joints, and everything orthopedics. I'm your host, Lauren, and today's episode is one that hits close to home for a lot of patients, providers, and families across the country. We're talking about opioids, and not just the crisis that we all know about, but the solutions that are emerging from not only within the medical community itself, but from within our walls right here at Rothman Orthopaedics. Here with us today, we have Dr. Asif Ilyas, one of Rothman's very own hand and wrist surgeons. Dr. Ilyas serves as the president of the Rothman Opioid Foundation. That's right. Rothman has its very own opioid foundation. And Dr. Ilyas is going to tell us all about it. He's been a leading voice in reshaping how we think about pain management, especially in the surgical space. And he's here to share with us what's working, what we've learned, and what's still to come. Dr. Ilyas, welcome. Thank you for being here.
It's my pleasure, Lauren. Thanks for having me.
Yes. Okay. All right. So this is a stat that I read this week, and here's the reality, the sad reality, that in 2023 alone, over 112,000 people in the United States died from drug overdoses. And according to the CDC, more than 75% of those deaths involved opioids. So that's roughly one death every 5 minutes. And many of those started with a perfectly legal prescription after surgery or after an injury, which is beyond heartbreaking. So the good news is that change is happening, and you are a reason for this change. So tell us, how did the Opioid Foundation get started here at Rothman?
Thanks for the question, Lauren. It was really based on the reality you just shared in terms of the statistics. When we launched the foundation, now about 7, 8 years ago, we were recognizing the increasing opioid-related deaths that we were seeing both in our community locally in the Philadelphia or the southeastern Pennsylvania or the Mid-Atlantic or the tri-state area, however you want to describe it, where we work, and broadly nationally that was occurring. And we also recognize that a lot of those opioid-related deaths were initially led by legitimately acquired opioid prescriptions for injuries and surgeries. And then we started to realize, like, listen, we have to be a part of the solution, not the problem, because as it stands, broadly, the healthcare community was a part of the problem. And I'll just take a step back and identify a couple important things. Firstly, the opioid crisis is multifactorial. It's not just doctors prescribing. It's not just, patients. It's a group of things. So first of all, there's the drug trade, which is an ongoing issue in America that's not new. It's been around for decades, and that's ongoing, unfortunately. And right now, it's being driven primarily by illicit fentanyl that's synthetically produced. That's the big player, unfortunately, in the market. It is opioid prescriptions from prescribers, partly, and partly it's the public. There are folks that have substance abuse issues and a disposition or propensity to substance abuse. They might have psychiatric or social dynamics or socioeconomic dynamics that might lend themselves to be susceptible to this. So we broadly recognize that opioid-related deaths are increasing, and you put forth an important statistic at I think around 125,000 deaths. But in 2021, the year after COVID started, was the year that opioid-related deaths surpassed 100,000. It's been climbing. And the last part I'll say to your first question is that there was actually a downturn in 24 a little bit, the first downturn in opioid-related deaths in many, many years, because even with increasing awareness, deaths were increasing year in and year out on average. But there was a downturn in 24, but we don't know standing in early 2025 if that was just a blip or a trend, right? So we'll see. But even if it is a trend, which is hopeful, it's still way too high.
Right. Yes. And that's what I read, that the CDC shows nearly a 24% decrease in drug overdose deaths from October 2023 to September 2024. So hopefully it is a trend and not a blip, like you said. We talked earlier and you mentioned that there are three core goals. There are three core goals of this foundation. Can you review what those goals are?
Sure. So in terms of the foundation itself, just as a way of background, it's a
Yeah.
501(c)(3)
Mm-hmm.
nonprofit organization. So it's important to state that it was born out of the mission of Rothman Orthopedics to identify to help combat this problem, and therefore a genuine foundation was created outside of the company to focus on this problem.
Yeah.
And the core mission of the foundation is threefold. First is to educate the public and prescribers on safe opioid use and prescribing, respectively. Number two is to perform and promote opioid sparing pain management research.
Mm-hmm.
And then number three is an advocacy role to advocate for a smart and evidence-based legislative policy around opioids and pain management for the public.
Amazing. Yeah. And we're going to get into all of it. I want to start with what is an opioid? We understand, yes, it's pain medication, but what is the difference? Why is it so addictive?
Sure. So opioids, first of all, I always want to say this when I talk about opioids, is that
Yeah.
I'm not anti-opioids. Rothman doctors aren't anti-opioids.
Mm-hmm.
They're very important. We can't do much of the surgical work we do without it. Every time you have surgery, an orthopedic surgery or any surgery, some amount of opioids are being delivered to
Yeah.
control the pain that you're experiencing. And that's a great tool. That's an
Right.
amazing tool
Yeah.
that allows us to do really painful and complex surgeries and manage difficult injuries effectively. So we need it. It's all about using opioids safely, what we now like to term opioid stewardship, and particularly
I like
in the post-operative, post-injury prescribing space, less about the surgical space, if you will. And we can talk about that as well. But in terms of what it is, it's been around forever. It's a very old medication, naturally developed, and what it does is it affects the brain. That's where it acts. It
Mm-hmm.
affects what's called the mu receptors, and that's how you perceive pain. So it blocks the mu receptors, and then pain experience is subsequently blocked.
Got it.
The problem with it is that you need, with constant exposure to it, you need increasing amounts of it to sustain the same pain
Mm-hmm.
relief.
So that's where
And
the addictive nature
that's what creates,
comes.
correct.
Right.
That's what creates the dependence on it, that you need more and more of it to control the pain. But the side effect is also there's a euphoria, a high from it. So
Mm-hmm.
not only are you controlling pain, it can create actually a higher euphoria that you need more and more of it to achieve, and that creates that dependency.
Got it. So you just mentioned that, so we probably will never get away from using opioids. It's just a matter of a safer use, a safer prescribing method for opioids. So there's never going to be a time, and I don't like to say ever, never, extremes like that, but they are needed, as you mentioned. So how have things changed? What's the big finding out of this research? So real quick, I apologize. Let me take a step back. What year did the foundation start?
2018,
20 2018.
18, yeah.
2018. Okay. So 2018 to 2025, what are the big findings that have come out of the foundation?
So many things. So we
Yeah.
focused our research on a number of things, and we continue to do this research and also diversify what we're working on. So in the beginning, we were looking at a number of things. So firstly, we were looking at and let me just preface by saying we've kind of focused on acute pain and surgical pain in the beginning, which is
Okay.
in contradistinction to chronic pain, cancer pain. There's different types of pains, but
Mm.
more in the post-surgical and post-injury pain. Now that we've since broadened, but that's kind of where we
Where we
started because
started,
that's
right.
where we saw the most of, and that's where we were seeing most of the abuse arising from, was
Okay.
in that space. People with
Really?
cancer pain aren't the folks that were concerned about developing abuse and dependency, and chronic pain is a different beast altogether, which we are now spending a lot of time in as well.
Mm.
What we were focusing our research on in the beginning was trying to understand prescribing patterns. So, in
Yeah.
terms of the prescribers, who's prescribing and how much and why. So,
Mhm.
try to understand what the current prescribing dynamics are. And we found that the prescribing levels were quite high. There was a lot of overprescribing that was occurring across specialties, not just orthopedics,
Right.
but broadly.
Yeah.
But orthopedics was a big part of that. And orthopedic surgery is known as the third largest prescriber of opioids
Mm.
behind pain management doctors, and you've got primary care doctors, then pain management doctors and cancer doctors. So we're pretty high and definitely the highest amongst the surgical specialties. So we're seeing who's prescribing what. And so then that's the first thing. And then how can we tighten that down to not over prescribe? So prescribe what people need, but not over
Right.
prescribe
And
because
why do you think they were overprescribing? So, for
I think
instance,
it's
I remember when I had my wisdom teeth out, that I got like this full bottle that could have
yeah,
lasted me a year, maybe. I don't know. And I didn't take any of it. I took a couple Tylenol. I was fine, but I had
yeah.
this full bottle of Percocets,
That
which,
that's a
yeah,
very common story. My own experience, having had some things done, the same experience.
yeah,
I think it was based on, first of all, I don't think it was malicious or malevolent.
right,
That's first thing.
right,
So firstly, I think it was just not being aware of the risks of
exactly,
prescribing,
right,
overprescribing,
right.
right? Making sure that an individual doctor's patient's pains are well maintained. There was some structural dynamics. It's very hard to, before the what's called e-prescribing,
Hmm.
you had to get a paper prescription to get the
Right.
medication. So this is something we had to deal with constantly up until the law changed in 18, where you had to get a paper prescription. So you, as a doctor, you wanted to make sure that you gave enough because if they ran out, they can't get a refill
I see.
easily.
Right.
Right, you have to go find a doctor
Oh,
to get that, right?
interesting.
And so
Right.
you overprescribe for the sake of the patient. But what that
Interesting.
led to is two big things. One is when patients are given more, there is a tendency to use more,
Yeah.
right? And this is just a normal human trait. We've studied this as well, that the more you give, more people take. The less
Yeah.
you give, the less people take. So the bigger the bottle, the more they'll take. The more you take, the more you get sensitized. So there is an untoward consequence of overprescribing, right? So that was one of the major issues. And the other issue was that in terms of the number of opioids that you're getting, is that as you get more, you become more sensitized to it and you need more. So
And you need more. Right.
what we realize is that when we can tailor the amount that we're giving is more effective. So one of the first things we do when we're studying and say, like, how much do people need?
Mm-hmm.
And that data was really amazing. And so what we realize is we don't want to give too much so they don't take too much. And the second part of it, I didn't complete my
Yeah.
prior thought, was this concept of diversion. So if your doctor gave you, say, 30 pills for your wisdom teeth, you
Right.
use two, right?
Yeah.
Fine. There's 28 pills sitting in your medicine cabinet,
Yeah.
right? So anyone in your sphere of influence, anyone that comes into your house has access to it. Could be
Mm-hmm.
spouse, could be kids, could be relatives, could be friends. In my own home, I have three teenagers now, almost not teenagers. There's kids in and out of the house all the time, so they're in my sphere of influence. They can open up a medicine cabinet and access it. This
Absolutely.
is the concept of what's
Oh
called
my God.
diversion.
Yep.
So just extrapolate you getting 28 more pills than you need to all of the surgeries, all of the procedures in a day being done in one town, one state, one country. We're
Mm-hmm.
just disseminating all of these opioids into the community. So
Wow.
people take more when they get more, and if even if they don't use it, it's available for abuse called diversion.
Oh my gosh, Dr. Ilyas, that just I read Matthew Perry's book not that long ago. I know
Mhm.
Matthew Perry from Friends, and
Mhm.
he had a major problem. And
Chandler Bing.
yeah, Chandler Bing. Oh, I'll cry right now over him. But it started with a shoulder injury.
Mhm.
And the physician that he had prescribed him medication, and you know what he would do? Once he became addicted to it, he would
Mhm.
go to open houses in the area and act as if he was interested in buying the house, and would go to their medicine cabinets
Yes.
and so sad, so sad. But yeah, they would. So okay, so we're talking through the different findings that have come out. So, how about for you personally with your own prescribing of medication? Were you a high prescriber, and then after these studies came out, decrease the amount? How did it work for you personally?
Absolutely. I'm as guilty as everybody else.
Yeah.
I finished my training '06, '07 time period, and like all my peers at that time, you had surgery, I'd give you 30 pills. I wasn't
Really?
I wasn't customizing to having a big surgery or a small surgery, and that was pretty customary. And so it's for the reasons mentioned. We didn't realize the risk of it. We wanted refills
Yeah.
were hard. We didn't want our patients to suffer. We didn't need
Right.
complaints, phone calls. We just sent it out. But we've now since learned that we have to really tailor this
Yeah.
down to what what patients need to control their pain well. It's not like we're under controlling pain. Much to the contrary, the newer research we're doing has shown that when we apply more deliberate pain management strategies and what we now refer to as multimodal pain strategies, patients actually do better from a pain perspective and
Really?
need much less of the dangerous stuff.
Interesting. Interesting. So what was the patient reaction like for you? What was it even known? Like, so, would a patient know, oh, normally I would get this amount of pain medication as opposed to this? And was it a problem at first?
Perhaps at first, but I'll tell you, awareness has gone up
Yeah.
significantly the past
Right.
five
So
to 10
that's
years.
helped. Yeah.
Absolutely. And amongst the public,
Mm-hmm.
amongst prescribers, through all the statistics, government policy, popular media, people really are aware of this. And so now it's not a hard sell. And I find, and we can talk about some of the strategies that we do,
Yeah.
patients really appreciate that we're really deliberate and thoughtful
Yeah.
about this.
Totally.
And I believe broadly, opioid stewardship is about being deliberate and thoughtful. It's not
Yeah.
about patient suffering or being stingy with it. It's about
Right.
having a strategy that we're deliberate about it. And I would say broadly, people have been really receptive. And I'll just make a quick little like side thing. I think actually more than anything that's happened, I think all the popular media has really driven awareness.
Yeah.
When Netflix or Hulu carries a show on
Yep.
this, that's going to get
It
across to
hits.
more
Yep.
people
So
than
many
any
people.
research done at any institution or foundation, and even more so than government policy. But I would say collectively, popular media, government policies have really tightened on this in terms of what we can prescribe. Even in Pennsylvania, the rules have tightened up quite a lot since 2017.
Right.
Um, new new legislation around e-prescribing, which we help champion. One of the things that we
Yeah.
champion as Rothman Orthopedics with the state, with the state society known as the Pennsylvania Orthopedic Society, and then our state legislature was driving e-prescribing, recognizing that part of overprescribing was related to the old-fashioned paper prescription
Mm.
dynamic, right?
Right.
So that was a big thing. And then the prescription drug monitoring program, which is also something that we champion, that allows doctors to see what are patients getting in general, right? So there can be some monitoring, and that creates a more honest, transparent system. And it makes, it gives the physician more data. It allows for more transparency for relative to the patients. The pharmacies can see, and that also has made a big difference in terms of prescribing habits.
Are there any physicians out there that are still paper prescribing, or is it mandatory across the US that e-prescribing is the way to go?
I can't say across the US because actually, interestingly, the prescribing rules are different from state to state.
Right.
But for Pennsylvania and New Jersey, I can tell you it's electronic only.
Wow. So, from our foundation, we were able to champion that for the state of Pennsylvania.
I would tell you that the work that we're doing is well beyond the state of Pennsylvania. But yes, in terms
Right.
of the legislation I referenced, e-prescribing and prescription drug monitoring program, we absolutely champion that.
Yeah.
And I
So, what did
think
that
those
consist
policies
of?
have blossomed beyond the state.
Yeah. What did that consist of? Like, how did you make that happen across the state? I think that's so
So
fascinating.
absolutely. So we this now we're going back almost 10 years now. We started working with our legislators about helping them write. So the legislators have to write the bills, right? Write the
Right.
bills that say, hey, listen, we have to go to an electronic prescribing system, not a paper prescription.
Mm-hmm.
And then we help support that, provide the evidence, the data, the background, and then they put that forth to legislature. Legislature passes it in the House and the Senate, and it goes to the governor. In Pennsylvania at the time, it was Governor Wolf.
Right.
I was actually at the signing ceremony
I
for the
remember seeing the
e-prescribing.
pictures from
Yeah,
that.
the
Yeah.
e-prescribing.
Oh,
Yeah,
we'll
it
have to
was
get a
nice.
pic of that and flash that. Yeah.
Absolutely. I look a lot younger in it, so you may not recognize me. and a lot less grays back then. And then the other thing was the prescription drug monitoring program was the other big thing that we really helped drive, because we realized that we need to have a modern system to look at. There's no reason at this day and age that we can't look at a computer screen and see what people are getting when it's a controlled substance, and that's also been really been helpful in terms of monitoring and regulating.
So, question about that. So, are you talking about multiple providers that a patient may have? And so you have access to see everything that that patient is being prescribed. So, you already know, say, if their primary care, it has them on a certain medication, that you're not over prescribing something. Is that what you mean by the monitoring system?
That's exactly right. So if
Okay.
I get a prescription, so Asif gets a prescription, my doctor will just put my name in as the patient and say, okay, has Asif gotten prescriptions from anybody else? And if I
Yep.
have, it'll say Dr. So and so gave, 20 Percocets on April 3rd,
Right.
right? And so not every drug, just the controlled drugs. So you have painkillers like your typical ones, your opiates, your typical
Yeah.
Percocet, Norco, Vicodin, etc. And then things like your what we call benzodiazepines, so like
Hmm.
Xanax, Valium, etc. And then a few other controlled substances as well, so that they can see and say, hey, listen, they can look for reactivity and cross reactivity issues, and also like, listen, you've gone a lot recently, we got to be careful about this, or maybe only one person should be prescribing your pain medication
Yeah.
on multiple people. That doctor shopping issue, that was something that we used to have to negotiate before,
Yeah.
because we were prescribing in a vacuum. We didn't know who's giving,
Who's
so
giving
now
what?
we
Right.
know, because there's value when it comes to opioids, both from dependency, and there's actually street value to it. If I prescribe an
Of course.
antibiotic or an anti-inflammatory medication, or a primary care doctor gives a blood pressure medication, et cetera, there's no value to those medications outside of their therapeutic value. But with opioids, there is both a dependency issue and a financial dynamic.
Absolutely. Are you relying on the patient to supply that information to you, or do you have access to it in like the e-medical records? How does that work? Because if you're relying on the patient, they can fudge that.
Absolutely.
They
No,
can
it's not.
fudge
It's
the
not at all driven by the
facts.
patient.
Right.
It's
Okay.
it is
Right.
it is a
Good.
state-run registry. We are all registered on it as prescribers, and we are expected
Ah.
to, before we write a prescription for a controlled substance like an opiate, we're supposed to
Yeah.
check it and say, hey, we checked it, no red flags. And so most EMRs, which are known as electronic medical records,
Yep.
which are a version of our charts nowadays, will have a prescribing tool, and then there'll be a box that says, "Did you check the PDMP?" And then you click that and say yes, and you have to
Amazing.
check it. So yeah, so it is an extra step. I'm not saying it's painless. It is an extra
Right.
step, but
For the
it is
safety
state-run
and for
data, not driven by the patient.
yeah, amazing. What are some other protocols that have changed because of the work that you've done in the foundation? Any other, as far as, I don't know, alternative types of medication that you're giving instead of the opioids, or you're just limiting the amount? What are some of the other things that are being done to alleviate that pain for the patient?
Well, I'll talk broadly first, kind of the
Yeah,
broad categories we're working on, then I'll drill down on a couple.
great.
So broadly, like I had mentioned earlier, we were focusing on kind of patient prescribing, I mean, doctor prescribing habits, patient consumption habits. Now we focus a lot since on sparing pain management strategies. So really around multimodal pain management. So what are things that we can do to decrease patients' re requirements for opioids, but still do a good job controlling patients' pain? So that's been a big part of what we do, and that includes preoperative counseling and other modalities.
Mm,
We've also been investigating alternative pain management, such as medical cannabis. Medical cannabis was legalized in Pennsylvania, New Jersey, New York, et cetera, not long ago. Pennsylvania was later than the other two states. I just referenced, I only mentioned those three states because we have a presence in those three states. And so we've been studying the role of medical cannabis for primarily chronic pain, but also acute pain. And more recently, we've started to spend more time research-wise in two other areas. One is around xylazine abuse, what's known as trank or trank dope. People who are injecting fentanyl in this area are often injecting fentanyl that's laced with a veterinary sedative called xylazine, and that's creating these really complex wounds that are basically toxic to your skin and your tissues. And we're seeing really severe wounds that people are presenting with really advanced opioid dependency. It's a really challenge to manage both surgically the compromised limb and then the addiction as well.
Wow.
And the last part is that we're spending now more time than we were previously is kind of focusing on chronic pain and the use of agents such as like buprenorphine, Suboxone, et cetera, in terms of chronic pain. As surgeons, that's a really big area for us because
Yeah.
every time we operate on patients, multimodal pain management is central to what we have to do. And traditionally, as we talked about, we'll just give, hey, listen, you had surgery, here's 30 or 40 Percocets and take it
Right.
as needed, right? That was kind of the mainstay for a long, long time. And we realize that's not the way that we should be doing things. We need to be more deliberate and thoughtful and tailor it. So firstly, this concept of multimodal is, can you tackle the pain experience of a patient at multiple levels, right? So
Okay.
when you have surgery, let's say surgery on your shoulder, just like we can see it in this video here.
Yeah.
You have pain when you're, making the incision. You have pain when you're manipulating. You have pain when you're cutting things, etc.
Yeah.
So you can affect the pain experience at multiple levels. So you can diminish pain by just numbing the area we're working. So it's like a local injection or a field block.
Okay.
Then you can also affect the pain transference of information up into the brain and
Right.
the spine. So there's ways you can slow that transmission down.
Amazing.
You can actually diminish the intensity of that transmission as well through anti-inflammatory and nerve
Wow.
modulators. And then you can block the perception of pain up top. That's what mostly
The
opioids do
opioid
for the
is.
most
Right.
part. So there's multiple levels that you can
Got
kind
it.
of affect the pain experience. So if you hit the pain pathway in multiple points, it diminishes the overall pain and requires you less use of opioids up top, right?
Interesting. Yeah.
So that means doing stuff like using nerve blocks or field blocks with local anesthetics, which are very inexpensive and very safe and tried
Yeah.
and true. Your lidocaines, xylocaines, marcaines, bupivacaines, Exparels, etc. Then there's anti-inflammatory medication, your good old-fashioned NSAIDs and the Motrin Aleve family, but there's more of them applied in different ways that we can use.
Right.
There's less dangerous pain medications such as acetaminophen, which is Tylenol, but we can give it intravenous, which is very powerful pain
Mm.
medication without the addictive effects. There's nerve modulators like pregabalin, which is Lyrica, or gabapentin, which is Neurontin, that can slow and modulate that.
Wow.
And then obviously centrally. So if we tackle it in multiple spots, it makes a difference. So most of our surgeons are going to do a combination of, they're going to use a local anesthetic. They're going to make sure that you're on Tylenol right away. They're going to make sure you're on an NSAID right away. They're going to make sure that you're using a nerve modulator like gabapentin, pregabalin if necessary right away. And then those are required medication. That's the secret sauce. This is not like take it if you need it. You
Yeah.
take those
You have
medications
to. Right.
and then you only take the opioid if you
If.
need it. And that then becomes the backup
Yeah.
for like you absolutely need it. And changing the paradigm of how we do it has changed the reliance on them, but
Mm.
also has improved pain management.
Yeah. So is it true? Because I remember from overseeing our Google reviews, I don't do that anymore, but I used to. And I
Good for you that you don't
remember
look at
this.
those anymore. That must be a brutal job.
Was it? Oh my gosh, that wasn't. I mean, here's the good news is that probably 90% of our reviews were 5-star. I'm not kidding. They were 5-star.
Sure.
Patients were so happy and so thankful to be moving and loved our physicians, great experiences. And then, you had your 10% that, had their issues or whatever. But I remember when a lot of these changes with the pain medication after surgery were going on, we were getting a number of negative reviews. And I don't know. And honestly, some of the patients were giving the review before they even had the surgery because they talked to the doctor and the doctor said, well, I don't prescribe pain meds. I would give you, Tylenol. So is that true that after like a joint replacement surgery, they would only get Tylenol?
I would the way I'd answer that question is that I think so much of it is really about how we communicate with our patients
Yeah.
about this, right? I think I would say, and I tell this to my trainees, when you're training, you spend most of your time learning your specialty and then developing your technical skills.
Yeah.
But in practice, the most important skill is communication. How
Yep.
well you can communicate things is really what matters, in
Yeah.
terms of setting expectations, understanding the
Setting that
recovery process.
expectation.
And
Yeah.
and let me tell you, I by no means am an expert at it, but I realize that that's really important.
Mm-hmm.
And I stress that to my trainees as well. So your example is really a great example of, what can happen if we're not effectively communicating that
Yeah.
information. So as I mentioned earlier, it's not about saying you can't have any, or
Right.
I'm not going to give you anything, or you're just going to get this and that's it. That language is going to be kind of not hospitable, I think. It's all about saying, like, listen, we have a strategy to manage your pain. It's a very deliberate strategy, so it's safer for you and more effective for you. But we do have medication for you if you need more. I never ever say you can't have anything for pain.
Yeah.
And my assistants know that if someone calls post-op for pain and they need a refill, and I give very small amounts of opioids, the answer for the first time is always yes, right? So because I know people's pain experiences are different, and I'm not going to sit there and pass judgment on how one person experiences pain versus another, particularly in the acute post-op period.
Right.
Now, once you start getting past a week, a month
Yeah.
after, then we're like, okay, that's not probably
It's
appropriate.
right.
But in the beginning, it's perfectly fine. But what's interesting is even though I never say no to a refill in the beginning, I can tell you that ever since we've instituted these multimodal regimens, it's so infrequent. And our
Really
data has shown that when we weren't doing multimodals and giving larger amounts, our refill rates were much higher.
higher.
When
Yeah.
we've gone to multimodals with much smaller amounts, our refill rates are much lower. There's a
That's
great
great.
study out of our practice at Rothman on outpatient hip replacement surgery, which really kind of nails it,
Yeah.
where there was a group that was getting 60 painkillers and another group that was getting a multimodal with 10 painkillers.
Right.
And the 10 painkiller group had less refills than the 60 count group.
Wow.
And so that tells you
Right
that it's
there.
not about it's about the multimodals and communicating and understanding kind of what it is. And broadly, we're not trying to have anyone suffer. And we know that everyone's different, and there are people who've had other, problems and pain experiences and other
Yeah.
comorbidities that may demand more pain medication. That's okay. It's not about the outliers who might have different needs. It's about the across the board broad population that 10, 5 to 10 to 20 to 100 surgeries we're doing every single day at a center, at a
Hmm.
practice, making sure that we're delivering good, safe pain management care.
Absolutely. What about people that have an addictive nature? Does that come, and I know that's hard to, I don't know if that comes up in the practice at all, and and I think that there's genetics with that, that addiction is a genetic true disease. Is there any way to screen for that before giving them a pain medication? I don't know how that works.
No, that's a great question and a question I get all the time.
Yeah.
I was just speaking in at Chicago at a department, and that was one of the main questions. And the answer is that we can screen,
You can.
but we generally don't screen. And let
Why?
me drill down
Yeah.
further on that. So
Yeah.
like if someone breaks their arm or leg,
Mhm.
they broke their arm or leg.
Yeah.
So we're not going to be like, okay, because you have these issues, we're not going to, we're going to do, we got to do X, Y, and Z. We still have to manage the injury, we still have to manage the problem, and we still going to have pain. So we have to adjust, right? So although in orthopedics, and I'm speaking only for us, I'm not speaking
Yeah.
for other specialties, other practices,
Got it.
you absolutely can screen. And I think for really elective surgeries and really elective practices, I think people are screening, and it's probably a good thing to do, or at least
Mhm.
that patients are prepared, like based on the screening, you're at higher risk for X, Y, Z, so we have to do this. I would say broadly, we don't do that as much because we don't have that luxury. People are coming in with problems that need to be addressed,
Yeah.
and so we don't always have the choice. We don't have an elective practice broadly, although there is very much elective components to what we do in orthopedics, at least. But the way I would say that is like, I don't get too concerned about what I call the outlier patient. If someone has comorbidities, be it psychiatric, socioeconomic,
Yeah.
other dynamics, then I'll adjust what I have to do for that patient, right? And
Right.
it's not like everyone has to fit in the same protocol.
Right.
So you're going to have your outliers. You're going to have to change your rules for outlying folks because of special dynamics. But it's about having making sure that you, Lauren, don't get 30 pills
Yeah.
after wisdom teeth, right? It's
Right.
about everybody else. The
Right.
outliers are the outliers. You'll customize to them, but it's to make sure that you have a broader protocol that the masses of people that you're treating aren't getting inappropriately and inadvertently sensitized when they don't need to be.
Yeah. Wow. So what's to come? What are you working on right now? What's the foundation working on right now? Because I feel like you've done a lot. I mean, you've made a lot of progress in not that long of a time. 2018 wasn't that long ago when this got started. And congratulations. Honestly, you're saving lives. You're saving lives with this and making more productive, better lives from it. So congratulations on that. So what's happening right now? What are you working on? Tell us.
We're trying to do more work in the medical cannabis space.
Yeah.
And I really want to commend and thank my partner in crime, Dr. Ari Grice, in
Yeah.
that space, who
We got
leads
to
our
get
medical
Dr.
cannabis
Grice on
department.
here. Yeah.
Absolutely.
Yeah.
Because it's important for us to really understand medical cannabis. It's been legalized in Pennsylvania and across the majority of states. How it's being used, how it's being prescribed and or certified, how it's being produced, how it's being regulated is kind of all over the map right now. And at a federal level, it's still a controlled illegal substance, but at a state level, it's not at many states. So it's in a little bit of a wild, wild west kind of
Yeah.
space. And I think we have to be responsible about it and really understand it and do some good science around it. We did a survey study on medical cannabis use, just surveying our patients in general, not
Mm.
specific to any problem, just coming in from musculoskeletal problem. And this was 4 years ago, I think, and right around COVID. And we found that 10% of patients were using medical cannabis for something.
For something.
That's an
Right.
enormously high number.
Yeah. Well, very good. Thank you so much for carving time out for me. Thank you to Dr. Ilyas for joining us today and for shedding light on opioid use, management, and reform. And thank you to you for listening. I'm so grateful for your time. Stay tuned for more episodes. And until then, stay healthy, stay strong, and take charge of your health. I'm Lauren, and you've been listening to The Breakdown.